We are live, so we can go ahead.
Okay, great. So good afternoon, everybody. Today we are going to talk about safe surgical dislocation of the hip joint. This is a technique which was really put forward by Ganz from Bern and has become an approach to the hip joint which is used quite often with a number of indications for doing it. Okay, so what we're going to discuss today is what do we mean by safe surgical dislocation of the hip? What are the indications, the approach, the surgical technique, and also talk about some of the problems and complications. Okay, so I think essentially this is an approach to the hip joint. This is not a procedure in itself, but it's an approach to the hip joint which involves dislocation of the hip. Okay, now, whenever you think of dislocation of the hip, you're worried about the blood supply. The idea is to dislocate the hip without compromising the blood supply. And this is based on detailed supply of the blood supply to the femoral head, and was described in this article by Ganz et al. In JBJS in 2001. Okay, and the vascular supply was actually studied by them in great detail in multiple cadavers, and they found that 90% of the blood supply to the head came through the branch of the medial circumflex femoral artery, and which came posteriorly very close to the region of the trochanter, and then gave these retinacular branches which sort of came along the capsule, especially in the superior and posterior part of the head, and then supplied the head. So they devised this technique by which you could do a trochanteric flip osteotomy, go anteriorly and dislocate the hip anteriorly, yet maintaining the blood supply in this through this capsular structures and retinaculum to the head of the femur. Now, in the bargain, there have been a number of indications for which this can be used, in which you need good access to the hip joint, the femoral head, and the acetabulum. So, femoroacetabular impingement is a good indication for it. Slipped capital femoral epiphysis. So, this is another area where this has becoming increasingly used, where instead of for some of these both the reduction and for osteotomies, instead of doing it by other approaches such as the fish osteotomy or doing closed sort of pinning in situ, today the preferred treatment is often reduction of the head or osteotomy with a safe surgical dislocation. Multiple other reasons why you might want to dislocate the hip and be able to access the hip and acetabulum adequately. Today, there are some new techniques such as the femoral head reshaping as well as the reduction osteotomies. But probably for orthopedic surgeons, general orthopedic and trauma surgeons, the two big areas for the use of this approach would be in the treatment of femoral head fractures, especially if it is along with an acetabular fracture, and also in some acetabular fractures involving the posterior part where the superior wall extension may go quite high up or more anteriorly, as well as in some transverse fractures of the acetabulum. So these are the areas where this trochanteric flip osteotomy or a safe surgical dislocation would give you much better access than you can get with traditional approaches. In fact, this was where in a way, the trochanteric flip osteotomy for safe surgical dislocation was originally described through the Kocher-Langenbeck approach, and this is still used for acetabular fractures. However, for a lot of the other things such as impingement, etc., the Gibson approach is preferred, And this is actually was described by Gibson, a surgeon from Winnipeg, in 1950 as an alternative or a modified posterior approach to the hip joint, where he made the incision a little more anterior than the original incision, although it still had a posterior curve to it. But the important thing was the approach to the next layer, to the deeper layer, was not through the gluteus maximus muscle, but between the tensor fascia lata and the gluteus maximus muscle. So it was in an internervous plane, and the entire gluteus maximus was retracted posteriorly. Interestingly, in the approach described by Gibson, he did not do the trochanteric flib osteotomy, but actually divided the sort of insertion of the gluteus medius onto the trochanter, and that gave him a very good approach to the hip joint. However, the approach as it is today does not incise the insertion, but does a trochanteric flip osteotomy with the gluteus and the vastus still attached to it. Okay, now this is done in a lateral position, the lateral decubitus. You must make sure that the patient is properly in the lateral position when you do it. And your incision is along the shaft, maybe just slightly posterior to the center of the shaft of the humerus, okay, or even at the center, and extends up a fair way from the trochanter and also down. So the incision is fairly long. You go through the fat and subcutaneous tissue and then come to the deep fascia of the thigh, okay, and then you incise the deep fascia. When you're going up to the superior part of the incision, you, instead of going posteriorly and dividing the gluteus maximus muscle, you actually go anterior to the gluteus maximus and go between, as I'll show soon. Yeah. So you go between the gluteus maximus and the tensor fascia lata. So that's the plane of your dissection, which is relatively avascular if you can find exactly the right plane, and then you push the entire gluteus maximus posteriorly. You need to divide the insertion of the gluteus maximus, and that would depend on how posterior you need to go, so that if you release it, it makes it easier, especially for your acetabular approaches, to go more posterior to approach your acetabular fractures. The next step is to separate out the muscles, so the gluteus medius and minimus muscles, as they get attached to the trochanter and the vastus lateralis. So you make a plane deep to the vastus lateralis, and here the osteotomy should exit not like the traditional osteotomy at the base of the trochanter, but at the tip of the trochanter, leaving some of the attachments of the gluteus medius with the deep plane. And of course, you should not disturb the attachment of the piriformis to the inner aspect of the trochanter, because that is where the vessels are very close. And if you're in this layer, you should not disturb or compromise the vascular supply. Okay, so that's how you do your osteotomy. Originally, again, done as a straight osteotomy. But if you want, you can zigzag it. So you go like that, and like that, because that makes the fix. You make your marks here in this direction, and then you make another cut slightly like that. So you get a zigzag approach to the, you cut the two limbs with the saw. Okay, so you're cutting it, and this is important that you leave a thickness of about 1.5 centimeters of the trochanter. This should not be too thick or too thin. So you cut the two limbs. Portion, you use the osteotome to cut through, and then once you've gone all the way through to the anterior part, so this osteotomy starts on the posterior part and then goes anterior. And once you go all the way to the anterior part, you can flip this trochanteric fragment along with the attachments of the glutei, the gluteus medius and minimus, and the vastus. So people call it a digastric or even a trigastric, because all the three muscles actually attach to this fragment. And then along with this fragment, you go anteriorly along the capsule of the hip joint. And this is where you have to do very careful dissection. You may have to sort of incise through some fibers of the gluteus minimus to get onto the capsule as well as lower down of the vastus. And you get the how you're taking the trochanteric flip fragment anteriorly along the capsule and until you get the whole capsule exposed. And then you do your capsulotomy. The capsulotomy has to be done in a particular way. You go along the anterior superior part of the neck, okay? So, and then turn it down. So we'll show you the details, but you start and get into the, through the capsule here, you get your sort of fluid or blood or whatever is in the joint coming out there. And then you cut from within to outside from the near the trochanteric region in towards the hip joint till you get to the labrum so that you do not damage the labrum. And once you get to the labrum, then you extend your capsulotomy posteriorly. So that is how you go. This is along the anterior superior part of the neck. This is the lower limb, and the posterior part of the upper limb of it goes along the joint posteriorly quite a long way. So you have to be able to retract these muscles quite a long way, and this goes along the labrum posteriorly. And once you do that, you can dislocate the joint by going into external rotation and adduction. You can use a bone hook gently on the neck to pull it out. So rarely you may have to divide the ligamentum teres to get the head out. And once you do that, you can put in your levers and get a really almost a 360-degree view of the acetabulum as well as a complete view of the femoral head, which allows you to do multiple procedures. So apart from the number of procedures I've mentioned earlier, even if you have loose bodies in the acetabulum or multiple osteochondromatosis and villonodular synovitis, all these things, this gives you a really good access to be able to remove those, sort of deal with those pathologies without affecting or compromising the blood supply to the femoral head. Now, this is the case where I showed the initial studies. This was actually an acetabular fracture, as you can see, with quite a superior extension and also marginal impaction here. And so here, that's the impacted fragment, which you have to get down to the head and align it with the head. And in this case, because it was quite a thick fragment, we could reduce it and then put wires on it and then replace those wires with these kind of headless screws. We use the locking head screws, so which have a very small head to fix that. And once you fix that fragment along with the femoral head, you then can put your larger acetabular posterior wall fragment back on it, fix it with a couple of lag screws, and then go on to do your buttress plate on it. So this is the intraoperative pictures. You can see these two screws are holding the impacted fragment, marginally impacted fragment. These two screws are holding the main posterior wall fragment. And then you put your plate on as you would do normally to buttress that fragment. And then the closing of the trochanteric flip, because it's still attached to all these muscles, it just tends to fall back. And all you need to do is to put two 3.5, so that's what we always use, 3.5 millimeter cortical screws, which start from the top of the trochanter and go towards the calcar. Okay, so this is how you fix the trochanteric fragment. And because it's attached to the muscle, it just tends to fall back and doesn't get sort of pulled out very easily. And this is the post-op X-ray. Again, you see all the various views, the obturator and iliac views, showing a good reduction and fixation of this posterior wall fragment and impaction. So here's another article which gives you a good detail of this technique. So I showed you the one from Ganz originally, and this is another article from Helfet et al. In JOT Trauma 2005, which again gives you the steps of the procedure in great detail. So those of you who want to learn it should actually go through these articles, because it's important to know all the steps, be aware of this vascular anatomy at the back, these retinacular vessels, You really need to get familiar with it before you start doing the procedure. And this is the direction of the capsulotomy, as I showed you, goes along the posterior superior of the neck posteriorly, and the lower limb which goes towards the lesser trochanter. This is the area through which the head will be dislocated.
I
mentioned the other area is femoral head fractures, and varieties of femoral head fractures, and depending on the situation, you have to decide your approach. So if you have a femoral head fracture which is irreducible, then you have to go posteriorly to reduce the dislocation. Okay, now having reduced it, it's difficult to fix the head fragment from behind because very often the fracture line is more anterior. Okay, so, and you can fix it from the back, but studies more recently have shown less AVN if you then do a trochanteric flip osteotomy and then fix it from the front. If you have a femoral head fracture with a dislocation which gets reduced, then you have a choice between doing an anterior approach, modified Smith-Peterson or Uter approach, or do a safe surgical dislocation and do it this way. So, but you have situations like this where you have a femoral head fracture and acetabular fracture as well, and with the femoral head lying posteriorly, where you do have to start posteriorly. So now you can see there's the acetabular fracture, quite a big chunk. This is the femoral head fragment lying at the back, and you have this head which has then gone back in and is more anterior there. Okay, so from the back we could retrieve the head. You can see the indentation in the head. Once you've got the head fragment out, then you do your trochanteric osteotomy. You flip the osteotomy that you've done, and now you dislocate this anteriorly. So this is the head with the sort of fractured fragment there. Okay, so now what you will need to do is to fix the head back in there. Okay, so that's the head fixed back. You can use headless screws, or what we tend to use are the 3.5 millimeter locking head screws, which give you quite a good hold. And then once you've done that, you reduce the head. We go fix the acetabulum, and everything else goes back in as well. Okay, and then finally you complete the trochanteric flip osteotomy with these 3.5 millimeter cortical screws. Okay, so these are the post-op views, the obturator iliac views showing good, and the 3.5 year follow-up on this patient. Of course, he's got some evidence of AVN, but the joint is still good, is still functioning okay, and has no pain at that stage. The other area which I mentioned was SCFE, or slipped capital femoral epiphysis. Here's a young boy in about 13 who is a chronic slip but with pain. You can see the bump here on the posterior side. I'm not showing you the CTs, but again, we use this lateral position. That's your incision, dividing the fascia lata, getting into that plane between the tensor fascia lata and the gluteus maximus. You isolate out the trochanter, you dislocate the here's the trochanteric fragment. This is anterior, this is posterior, here's the osteotomy. And this is the entire capsule. You can see how beautifully the whole capsule is visualized. And then you will do your capsulotomy again, here, here, and then go across like that, okay? And then you dislocate the head. You can see all this callus that is forming here, the bump anteriorly. This is the trochanteric side, this is the head side with the head there. And then you have to actually almost do an osteotomy. You can use a sharp osteotome or a combination with the saw and the osteotome, but be very careful when you're cutting this wedge of bone down so that you don't cut too much, nibble out the extra bit. Make sure your retinacular flap to the head remains intact. And then once you take out the wedge, you can reduce the head back in, fix it. So you first fix it provisionally with wires, then with screws, then you relocate the head and fix the trochanteric flip osteotomy with screws there. And this is the post-op X-ray. And this is 11, and this is in 14, a 3-year follow-up showing him doing well with this. And you can see again, there's no bump, there's no anterior impingement, which would cause restriction of motion. The other area which we discussed was impingement syndromes. And I think today we know a lot of the osteoarthritis, which was previously termed as primary osteoarthritis, are related to impingements of various forms. You have the cam impingement or the pincer type of impingement. This approach is really suited for the head reshaping, for the cam type of impingements. You can do labral repairs, etc. Now, this is a patient who presented to us already with osteoarthritis. But again, if you look at the pictures, this is the CT scan. You can see the impingement here on the anterior part. You can see the osteophytes there. There's already some osteoarthritis in the joint. So it's not the ideal time to do it. Ideal time would have been a bit earlier, but this is when they presented to us. And you can see all these osteophytes in the anterior part where the head is impinging against the sort of labrum and the anterior part of the acetabulum. So again, you can do your safe surgical dislocation. That's your trochanteric flip osteotomy. You're taking off the trochanter anteriorly. This is once you've dislocated the hip. And again, you can see all these osteophytes in the anterior part. So you can use your osteotome to remove all these osteophytes, reshape the head as best as possible. And then once you've got it, sort of make sure that your neck is not impinging on the acetabulum, you reduce it, fix your trochanteric flip osteotomy again. That's the post-op X-ray. And this is a 2-year follow-up on this lady. She's doing quite well so far, but there is already some osteoarthritic changes. So, but at least in a young patient, we've managed to gain a few years before she goes on to an arthroplasty of some sort. So I think this may not be the ideal time to do it, but still may give you a few years. But you should warn the patient that eventually, once osteoarthritis has already started, may be a little late to prevent progression, complete progression of the osteoarthritis. You may be able to delay it. Of course, this is not indicated in patients who are non-ambulatory. If there's any local infection, this is not surgery you want to be doing, or if patient is unfit for surgery. So moribund patients, patients with multiple medical comorbidities, you would want to avoid because it is reasonably major surgery. And as I mentioned, once you've got symptomatic osteoarthritis, this is a relative contraindication for doing it. You can have complications, although in the hands of the originators, Ganz, etc., they reported in the first paper in more than 200 odd cases, not a single case of avascular necrosis. But I think, again, they are the originators of the technique. They learned the details of the anatomy and obviously knew the anatomy of this area so well. In their hands, they had very few or almost no avascular necrosis related to the procedure. This is what they claim. Of course, many people have been doing the procedure and you get varying rates of avascular necrosis. Heterotopic ossification, interestingly, even in the Ganz series, they had almost over 30% of heterotopic ossification. Only 3 or 4 of them were significant, and in that first 200, I think there were 2 where they had to go back and do excision of the heterotopic bone. Sciatic nerve palsy, this is when you go to the back, you have to be careful. Again, in the initial series, 2 cases of sciatic nerve palsy. We have in our series had 1 which was recovered in about 3 to 4 months. But it's something you need to be aware of and try to avoid and be really careful in your dissection posteriorly. And some people have even suggested neural monitoring when you're doing this. Delayed union and non-union of the trochanteric flip osteotomy. We have not had any in our series, but in a Ganz series, I think they had a few. I think 3 were non-unions. So again, you need to make sure that you get a good fixation on your trochanteric fragment. You can pre-drill it if you like. That's another way of doing it, is to pre-drill it. We haven't been doing that because eventually this fragment seems to fall back okay. And in that area, even if you drill the hole earlier, it's difficult to find it later. So we just tend to do the drilling at the end. Interestingly, one complication they wrote about in that series is this saddleback deformity of the subcutaneous fat. Okay, now, saddleback deformity of the subcutaneous fat. Okay, this is something related to the closure of the subcutaneous fat, and you get this sort of little ugly sort of deformity of the subcutaneous tissue. Especially in ladies, this is something that is not cosmetically very good, but it's no significant, not a functionally significant problem. So all these things you need to be aware of. Okay, so in conclusion, I think this is a very useful technique. However, and really the indications, there are a number of situations where this can help you. You need to have a thorough knowledge of the anatomy. This is important, especially the vascular anatomy and the neural anatomy. And your surgical technique is really important. I think, again, the originators really paid a lot of sort of care and were very careful in their technique of doing it, and therefore they had very low or almost negligible AVN rates. And you, with good surgical technique, you should be able to minimize your complications, because there are significant potential complications, and I think your technique becomes important to minimize the complications. So thank you. Okay. Stop sharing my screen. 1 second.
Sir, good evening, sir.
Yeah. I would like to.
Okay, yeah. Yeah, so any questions?
Sir, intra fracture of neck of femur, can it be a potential complication?
I think, see, it's not something that should happen, okay?
I mean, sir,
So you have to be careful when you do your osteotomy that you don't go through, okay? Now, when you're doing it for a skiffy, you're actually creating a fracture,
yes.
Okay? When you're doing, it's an osteotomy, although it's a wedge osteotomy, and on the other side, from you're starting antros superior and going posterior inferior, on that side, it's just, you try to keep the sort of attachment intact, but it's actually a through and through osteotomy. So it's actually a fracture if you look at it that way. But otherwise, when you're doing other procedures such as impingement or acetabular fractures, etc., you should not create a fracture of the neck. So I think potential complications could be anything, but what are the likely things which you need to be really careful of? So I think as long as you don't use excessive force when you're trying to dislocate the idea is that you do your capsulotomy in such a way that getting the hip out actually is quite easy. Okay.
Sir, can we write it in exam along with other complications?
Yeah, I'm sure you can write it in the exam, but you should have the likely complications first and then the less likely complications later, okay? And it's like every time you do a prosthesis, you can create a fracture of the shaft of femur, but that is something which shouldn't happen, huh? Yes. Can happen, but shouldn't happen. Well, things like heterotopic ossification is something which may be unavoidable in a certain number of cases. AVN, again, I think if you look at the...
Sir, in case it happens, sir, during surgery, then
you fix it. You're in a position to fix it.
Any original plan, should we retain it, or is there some change?
So in a young patient, definitely you will retain it, huh? Okay. In an older patient, you may think of an arthroplasty, yeah.
Yes.
So like if you're doing a femoral head fracture and you create a neck fracture, okay, then in an elderly patient, it may make more sense to do an arthroplasty. But for younger patients, you would still first try to fix it, yeah. Why are we seeing two of Janki?
Yes, sir, just a minute.
So other questions?
Good evening, sir.
Yeah.
In contraindication, you have mentioned non-ambulation is the contraindication.
Yeah, so if a patient is not, so suppose he has an acetabular fracture but wasn't walking before the acetabular fracture. So why are you going to do all this for him? So we are talking about non-ambulatory prior to the pathology.
Okay, sir.
And this is specific, particularly for acetabular fractures. If the patient is not walking or is already sort of bound to the bed, or then it's no point doing major surgery to fix the fracture only to have him not walking again. Yeah.
Okay, sir.
Of course, if he's not walking because of the pathology, that's a different issue. Huh?
Yes.
So I think the important things to remember are how you do first the approach, where you do your osteotomy, why you do it there to avoid damage to the blood supply. Okay, the direction of the capsulotomy, again, that is related to the retinacular blood vessels, which are in the superior part of the capsule. So you go just anterior to that and then go posteriorly at the level of the joint of the labrum. So by then, whatever blood supply to the head has to go has already gone into the head. Okay, so you don't cut through the blood supply to the femoral head. Okay. Janki, can't hear you. We can't hear you, Janki. Are you?
Hello. Yes,
Yeah, now we can hear you.
sir. Any role of vascular surgeon after cutting the lateral circumflex artery?
What is the vascular surgeon going to do?
Anything other things, sir?
So lateral circumflex femoral is.
Sorry, medial circumflex, sir.
So they are, I mean, at that level, trying to repair that vessel is very difficult, okay? It's not like the femoral artery or the brachial artery or something like that. I think if you cut it, you just hope for the best that nothing happens.
Okay.
Sir, that usually cam lesion is in anterolateral part, sir, and where
Yeah, I think your connection is not good. We're not hearing you.
Okay. Now you are able to, sir?
Better?
Hello.
Yeah.
Yes, sir. Sir, usually anterolateral part cam lesion, when you are dissecting it, sir, what precaution we have to take? Because retinocular vessels are also very close to it, sir.
No, so again, this is what I'm saying. The retinacular vessels are coming through the capsule in the superior part. Yeah. So your capsulotomy incision should go along the neck, and once, like I showed, you make a full thickness division of the capsule near the trochanter, and then go in that direction from inside out till you get to the labrum. And the idea there is that you don't damage the labrum. And then once you get to the labrum, then you go posteriorly. So if you do that, the vessels have already gone into the head. So that part of the capsule, the blood supply has nothing to do with the head blood supply. Right?
Okay. And sir, for trochanteric flip, one more technique is step cut osteotomy they have described in the book. So
that's what I showed. The one
that one is
in the video. So you make two cuts and then a cut joining the two. Okay. So
Okay.
it's like a Z-shaped thing. Okay.
And sir, to prevent heterotropic ossification, you are using some NSAID, sir, or is it?
We're not specifically using it. I don't think we've had a major problem with heterotopic ossification in the ones we've done so far. I think that's related to how much you pull on the abductors more than anything else, and the dissection. So I think in the series that they showed, they had many acetabular fractures as well. So in acetabular fractures, anyway, it's a potential complications with the posterior approach. Okay. So that is part of the injury sort of pathology. Okay. Problems related to a acetabular fracture that you might get AVN. Okay. But for the others, it's not so common. When you're doing it for skiffy or head reshaping or impingement, it's not that common.
And sir, what all acetabular fracture we can have assessed through this approach, sir? Means what all part of acetabulum, sir?
So you can see a lot of the acetabulum depending on how far you do it. Okay. So classical is posterior wall where it's going more superiorly. Okay. So standard Kocher-Langenbeck gives you access to the posterior wall. But if the wall fragment is going more superiorly, then retracting the gluteus can become quite difficult. Okay. So there the flip will help you access that part. In a transverse fracture, if you want to see your intra-articular reduction, okay, so there you can actually do a safe surgical dislocation and actually look directly into the acetabulum and see how good your reduction is before you fix it. You can make sure you don't have intra-articular screws, okay, because when you put your anterior column screw in a transverse fracture, you can very often go into the acetabulum. Okay, so you can actually see that you're not going into the acetabulum and get the correct direction for it as well. Okay, so again, you can see how well your reduction is. You can see what damage there is within the acetabulum and the femoral head, because you're seeing the entire femoral head, if there's been any indentation, etc. Okay. So, and you can deal with some fractures which go almost not all the way anterior, but somewhat anterior. Huh? So the classical indications are these. Huh? Intra-articular loose bodies, etc. Sometimes from the back it's difficult. So once you do this, you can see it very clearly.
Sir, few arthroscopic technique is also described in the book for cam lesion and all. So do we have any advantage over that one, sir? Because
so I think arthroscopic technique is something which is more recent and has advantages in certain lesions. Okay, so a simple labral repair you can do just as well arthroscopically as you could do it open. You can do some amount of impingement management through the scope, but when it gets to more extensive procedures, it becomes more difficult. Okay. Now, also depends on the technique of the person doing it. Okay. So I think if you can do it well arthroscopically, there is definitely an indication for it.
And sir, if we compare the risk of AVN, sir, so in arthroscopy, it is comparable, or is it?
I think you can, you should not be going near the blood supply if you're doing it arthroscopically, but you can damage structures for sure.
Yeah. Because if it is.
Yeah, there is a report of nerve and vessel damage in arthroscopic surgery.
Because in literature also, when I have checked, sir, that in anterolateral part, when we are removing the cam lesion, the chance of damage is more in arthroscopically.
Yeah, that's what I'm saying. So that's what I'm saying. There's reports of both, but it's not so much of the head blood supply as the femoral vessels on the anterior side. Huh?
So, sir, any intra-articular lesion we can manage with this technique. So,
Yeah.
So other minimally invasive surgeries, what they have mentioned, I do not know if for smaller lesions, sir, other than arthroscopy, what we can use. Other than
So, I mean, so you can do like a capsulotomy and distract and see if you can get it out. If it's a loose body or something like that. Okay, so after all, we used to do that or we still do that for acetabular fractures with loose bodies. When we go from the back, we just distract it a bit, traction, and then pull out the thing. Okay, sometimes it can be difficult. Then this gives you much better access to it. So similarly for synovial chondromatosis, we could earlier do it anteriorly without the trochanteric flip, but then you are jeopardizing the blood supply more likely. With the flip, you are less likely to damage the blood supply.
So I think almost one more question for post-operative protocol, sir. Like after like for cam lesion when we are doing it. So partial
So I
weight
think
bearing.
most of these you can, there's no reason not to start mobilization. Yeah. So an acetabular fracture, obviously it would depend on how good your fixation is, but if there are multiple other injuries that may modify your mobilization, but usually you would get them to touch even for that, or for these cam lesions and all, you can start early weight bearing. That's not such a big problem.
Okay. And in case of tumors, sir, like a few intra-articular tumors also, this procedure has.
How does weight bearing matter? Yeah, you can. That's what I'm saying. So synovial chondromatosis, villonodular synovitis, all those news, osteochondroma involving actually going very close to the joint. You can do that. Yeah.
And for the sports activities, sir, how much usually it takes for cam lesion, specifically impingement syndrome?
I think usual would be, I mean, we don't do it for pure sporting things as yet. So, but I would say by 3 to 6 months, there's no reason why they can't start.
Okay, sir. So,
okay.
I think, yeah.
Yeah, should we call it a day?
Yeah, thank you so much, sir.
Okay, thank you, everybody.
Thank you, sir.
Thank you, sir.
Welcome. Sure. Okay, bye.
Bye, sir.